Welcome, everybody. Hi, my name is Zan Rothenberg. I'm one of the program co-directors for the Addiction Fellowship. I'd like to start by acknowledging that we're here today on the ancestral and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh Nations. And I have the pleasure of introducing Heppelll, who will be presenting on perinatal substance use and the child welfare system. Allie's been working at St. Paul's in the urban health unit for the last 2.5 years with folks who have infectious diseases as well as substance use disorders. She completed her master's in 2014 in Toronto and moved to Vancouver in 2017, where she had the opportunity to work with numerous different mental health, and addiction settings. As an addiction fellow, she hopes to reduce stigma and support best practices by amplifying the voices of pregnant and parenting women who use substances. With that, just some housekeeping. I'd ask that if you have a cell phone, if you're in the room, maybe you just mute it, and then you save your questions until the end. With that,
Hi, thank you for coming today. There's so many of you. So like Zan said, so most recently my experience has been here at St. Paul's in urban health, but I've had opportunity to work in a ton of different systems, including child welfare, and I just have a very strong interest in the way that systems interact, and particularly in instances where this creates barriers for marginalized populations. So in today's presentation, I'll just be talking about the latest evidence in the field of perinatal substance use. In particular, I want to highlight the intersection between the substance use and child welfare systems and how this impacts people who are pregnant or parenting and using substances, as well as the literature around what can and is being done to address some of these challenges. I also want to take the opportunity to say that these are both really big topics, and my intention today is to present the research that I found on how they both intersect. It's not my intention to present myself as an expert, and I want to acknowledge that workers in both these systems have incredibly difficult jobs, and are up against limited resources in the context of an increasingly toxic drug supply and ongoing opioid crisis. It's not changing. Sorry. So I also want to just acknowledge with gratitude that the land on which I live, work, and play as a white settler is the ancestral, unceded, and occupied territories of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I also just want to take this chance to acknowledge that the war on drugs disproportionately harms Black and Indigenous peoples and their communities, and that ongoing racist and colonial policies in both healthcare and child welfare systems creates barriers and causes direct harm to Indigenous peoples and their communities. And as we discuss the research today, I also just want to mention that Indigenous peoples, and especially Indigenous women, have been recounting their experiences and telling their stories for a very, very long time, contributing to a really significant amount of quantitative and qualitative research without getting much in return. Just really briefly, I have no conflicts of interest to disclose, and funding for my fellowship comes from BC Women's Hospital. So for learning objectives today, I'm going to present a review of the relationship between the substance use system and the child welfare systems. And I just want to note that provision of child welfare services differs between provinces and between countries. And so when we look at studies that have taken place outside of BC, I intend to mainly discuss the system here as a way to narrow the scope, but I'll let you know if the difference in systems is important to interpreting the literature. We'll discuss the evidence-based literature regarding the impact of the child welfare system on pregnant and parenting individuals who use substances, identify and discuss current models of care designed to address some of these issues, and then look at recommendations for application to social work practice. So really quickly, I'm going to review some key language and terms. I'll give you an overview of perinatal substance use in BC. We'll talk about the competing philosophies between substance use care and the child welfare system and the relationship between the two of them. I'll provide a review of the literature surrounding how the child welfare system impacts pregnant and parenting women who use substances, chat about models of care that support pregnant women and moms who use substances in the community. And then again, we'll just talk about what the implications are for social work practice and how it can be applied to the work that we do. So first off, just about some terms. The terms pregnant women, pregnant individual, and people who are pregnant and parenting are all going to be used just to acknowledge and be inclusive of transgender individuals who are pregnant, and to respect those who wish to continue to be identified as pregnant women or mothers. It also acknowledges that both women and people who don't identify with the gender binary both experience health inequities. Trans and non-binary folks are vastly underrepresented in this literature, which is a limitation of most of the studies that we're going to look at today. So when we talk about perinatal substance use, we're talking about the period of pregnancy to generally a year after giving birth. Definitions seem to vary in the literature, and some of it depends on programming. But generally today we're talking kind of up to 1 or 2 years after giving birth. When we talk about substance use, it can encompass both licit and illicit, prescribed and non-prescribed substances, including tobacco, alcohol, opioids, stimulants, and benzodiazepines. And when I talk about child welfare today, mainly what I'm talking about is MCFD, or the Ministry of Children and Families, or delegated Aboriginal agencies like Vancouver Aboriginal Child and Family Support Services, or VACFAS. So it's really important to know that the use of substances during the perinatal period is intrinsically linked with other societal factors, including poverty, racism, sexism, economic and political power. A recent 2021 study determined that the incidence of perinatal opioid use disorder has actually tripled over a 20-year period in BC. The severity of the overdose crisis since it was declared 8 years ago has also added significant complexity and urgency to addressing substance use among women. And while I wasn't able to find statistics specific to the perinatal population, data from the BC Coroner's report from July of this year indicates that the rate of female deaths from overdose have increased year over year and doubled between 2020 and 2024. So the Perinatal Health Report is a really important piece of gray literature that was published by Perinatal Services BC on maternal health, labor, delivery, and newborn health for all deliveries in BC. And the reports provide summary information to health authorities, policymakers, planners, and perinatal healthcare providers. And so there's just a couple of statistics that I wanted to highlight from the most recent report. So the chart shows the percentage of deliveries for use of cigarettes, alcohol, binge drinking, and other substance use or other drug use. In the report, other drug use is defined as the care provider documented that the mother reports use of drugs. So heroin, opioids, stimulants, solvents, cannabinoids, and even methadone. So at some point during the pregnancy, or the care provider lists use of prescription other or unknown drugs as a risk to the pregnancy. So the key takeaway here is essentially that cigarette use has been declining, alcohol and binge drinking have been mostly stable, and other drug use is the only category that's kind of been on an upward trend, with a slight decrease from 2020 to 2022, but still an overall upward trend. And so according to this data, 2021, 2022, 5.9% of pregnancies in BC involved illicit or other drug use. So knowing what we know about the rates of overdose in women, as well as increasing rates of the other drug use category, substance use in pregnancy, I just wanted to highlight some of the key differences that women face in terms of substance use, related both to physiological and gender differences. as well as a number of additional vulnerabilities that women face when it comes to substance use and substance use disorders. So this table was actually taken from the FIR model of care document developed by BC Women's Hospital. And so just a couple of like the important things to note is that physiologically women tend to have more cravings than men and may use smaller amounts of substances for less time before becoming addicted. Substance use also tends to progress more quickly from first use to addiction. In terms of gender, women more frequently experience interpersonal violence that increases the risk of substance use and are more reluctant to get help during or after pregnancy due to stigma and fear. A 2010 study conducted on perinatal substance use service provision over the course of 7 years was conducted in 2010 by Nichols et al. And they found that the construct of good mothering was identified as an important cultural norm that supported social stigma and was really embedded in healthcare providers' interactions with mothers with substance exposed pregnancies. And this stigma even more harshly targets poor women and women of color. And it has a significant impact on women's ability to seek substance use care, often due to fear of child welfare consequences. And so because of that, I think it's really important to understand the historical context between the child welfare system and substance use and the policies that have had a disproportionate impact on Indigenous populations and the overrepresentation of Indigenous children in care. It's essential that we understand that this colonial structure remains and it continues to cause significant harm. This is by no means a comprehensive summary, but it reflects some of the most important terms and periods of time, which I've kind of presented separately because I really want to highlight that First Nations child welfare started with residential schools, which, as we know, had nothing to do with the welfare of children. And that was initially separate from provincial child welfare legislation. So just a couple of important points in time. In 1951, Section 88 was added to the Indian Act, which made it possible to enforce provincial child welfare legislation on reserve, and authorities began apprehending children and placing them with non-Indigenous families across both Canada and the US. And so this period of time that lasted into the 80s, we call the 60s scoop. Despite advocacy and some success in the 70s and 80s for Indigenous control over child welfare, Indigenous children continued to be taken into care at alarming rates, leading to what we now call the Millennium Scoop. During this time, birth alerts were used until they were actually declared illegal and unconstitutional in 2019. So these are notifications that were issued to hospitals regarding pregnant people, which required hospitals to contact child protection authorities when the infant is delivered. They can be based exclusively on suspicion of any kind of risk. And again, they disproportionately targeted Indigenous women. And so in 2018, before they were declared illegal, 58% of those were issued to Indigenous women. And so while we don't use them any longer, that trauma and that fear remains. And then just finally, Bills C-92 and Bill 38 are federal and provincial legislation passed in the last few years that allows Indigenous First Nations jurisdictional control over their child welfare and the ability to create their own legislation rather than simply applying or administering current colonial legislation. But that said, movement has been very slow and funding structures for that is not very clear. So like I said, Indigenous children remain vastly overrepresented in the child welfare system. According to the Representative for Children and Youth in 2019, child removals for non-Indigenous children have been decreasing over time while they continue to increase for Indigenous children. As of March 2023, the proportion of Indigenous children in care was 68%, despite them only making up 7.7% of the population. So you can just kind of see that the trend is down but the proportion of Indigenous children has gone up. So in terms of your duty to report, reporting to MCFD is not exclusively the role of the social worker, but with that said, social workers can support you with how you might go about reporting and best practices around providing support to the family. You also have no legal obligation to report prenatal substance use. So clinicians in Canada don't have that legal obligation, nor do we have a legal obligation to provide information to child welfare authorities unless there's a consent form in place. Also really important to note just that maternal substance use alone is not grounds for the apprehension of an infant. And I want to be really clear that I'm not discouraging that you report your concerns to MCFD, but what I am encouraging is that we think really critically about how and when we do this as clinicians, and what parents might already be doing to mediate the risk to their kids. I also want to state really explicitly that I'm not criticizing individual child welfare workers and that the harm being done is being done by a system that was historically set up exclusively for the purposes of colonization. So this is a project that stemmed from a capacity building initiative where Aboriginal mothers facing substance use and child welfare involvement expressed the need for improved relationships with these agencies. And so based on their recommendation, a study was conducted in Toronto from 2009 to 2010 involving focus groups with substance use counselors and child welfare workers, as well as storytelling circles with Aboriginal mothers. A number of key themes emerged around the concept of time. And so I'm just going to highlight a couple. The first is historical trauma and the fact that multi-generational apprehensions fuel mistrust. And the second is that counselors emphasize the deep history of colonization and the extensive time needed to heal from that kind of intergenerational trauma. And the second was high bureaucratic demands. So the child welfare system's bureaucratic demands often clash with the realities of mothers' lives. Excessive focus on compliance and case management creates time pressure on both workers and families, leaving less room for relationship building and providing support. Narrow parameters of time are also imposed on women to recover, which places significant strain on them and their substance use counselors. And counselors also noted that these time demands influence the treatment approach for mothers and fail to reflect the actual process of recovery. And so the study really concludes that current child welfare legislation, despite the stated aim to protect children, is actually causing significant harm to Aboriginal mothers and their families. And some of the recommendations around that include policies that reflect a family's full circumstances, so considering environmental factors, addressing the family as a whole, rather than placing mothers and children's needs sort of in clash with each other. Acknowledging historical trauma and the intergenerational impacts of colonization and enacting anti-racist and anti-colonial ways of assisting families, respecting the complex and time-consuming nature of healing, and enacting an actual Aboriginal Family and Child Services Act that encompasses Aboriginal worldviews and values. So this is a peer-reviewed conceptualization paper from the US calling for new approaches to substance use and child welfare. It highlights that substance use is a leading cause of child welfare involvement in the US. Here in BC, MCFD doesn't actually track substance use data specifically. They categorize it all under neglect. And so the only statistic I was able to find is actually from a 2002 report where welfare workers estimated that 70% of their cases involve substance use. Authors point out that cases involving substance use are often not just about substances, and they involve multiple other service needs, including poverty, housing, healthcare access, and co-occurring mental health disorders. Patients or parents are placed on really strict timelines for recovery to reflect permanency and case resolution timelines. But if we understand addiction as a chronic illness, This makes complete recovery really hard to establish and not very reasonable to expect. Child welfare interventions are not designed to address issues related to the nonlinear nature of addiction, which means that abstinence is typically the standard for reunification. Positive drug screens or relapses are often viewed as a sign that mothers are uncooperative or that they lack insight and that they won't be able to safely care for their children. And then punitive responses typically follow, such as switching from reunification to termination of parental rights. And the paper emphasizes that historically substance use has been framed as a moral failing, which is then reflected in even more punitive policy. In contrast, current treatment and recovery models focus on remission, symptom reduction, harm reduction, and understand that relapse is likely even upon the completion of treatment programs. So the recommendations from this article include ensuring continuity of care and long-term support for women, proactively planning for relapse, removing barriers to extended treatment, implementing harm reduction strategies, and integrating treatment for moms and babies together. Just to note some of the limitations, this article does use pretty stigmatizing language, so I've been saying substance use, they use substance abuse throughout the article, which I just thought was interesting, given that they are advocating for better care of this population, but also actively perpetuating stigma. And while this article was written in the US, there are several parallel themes in a bunch of the Canadian studies. And as we know, media rhetoric here has grown increasingly negative towards harm reduction models and people who use drugs, which ultimately influences policy, regardless of evidence-based research, which is a good segue to our next article. So this is a scoping review that was conducted in 2019 by authors with the Center of Excellence for Women's Health here in Vancouver. The aim was to understand how stigma impacts access to, retention in, and outcomes of harm reduction and child welfare services for pregnant women and mothers who use substances. So 42 articles were analyzed using the action framework for building an inclusive health system. And that was developed by Canada's Chief Public Health Officer to articulate the ways in which stigma and related health system barriers are experienced at the individual, interpersonal, institutional, and population levels. And the authors cite that among pregnant women who use opioids in particular, early and consistent access to harm reduction services, including opiate agonist treatments, is associated with fewer pregnancy complications, better fetal outcomes. However, pregnant women frequently face barriers to accessing services and feeling safe to disclose their substance use to service providers. Many of the barriers that women face are inflicted by pervasive stigma, which is particularly true for Indigenous women, women of color, and women experiencing poverty. So this article is incredibly thorough and it identifies numerous common themes throughout the levels of stigma, and we don't have time to talk about all of them, but I just wanted to highlight some of the key findings related to the child welfare system. And so within the individual level of stigma, a common theme was fear and mistrust of the child welfare system, which was identified in 13 of the 42 studies, and one of the most commonly cited factors. So fear and mistrust of the system significantly impacted women's access to harm reduction and social services. Women cited worries that their child would be removed from their care. Many of these fears were prompted by institutional and population level factors, including discriminatory laws and policies. The factors highlighted or heightened the internalized stigma, maternal guilt, and the belief that they had failed or that they were unfit to mother, and directly impacted their confidence in their ability to parent. It prevented women from accessing needed services such as prenatal care and counseling. It hindered their ability to seek support, which resulted in isolation and concealing substance use, even if they reported wanting help. And reluctance was amplified when women had intergenerational child welfare involvement and who previously had traumatic experiences. So within the institutional level, 5 articles described the impact of the child welfare system, which included distracting mothers from reducing their substance use or increased substance use after apprehension. Also at the institutional level, 3 articles discussed reunification timelines, which were also mentioned in the previous 2 articles. So just to be clear about that, child welfare policy dictates how long children can be in care before they need to be placed somewhere permanent or before parental rights are terminated. And that often doesn't align with how ready mothers are to have their children back in their care. Several articles described how women had high expectations placed upon them and an unrealistic number of tasks to complete. And meeting these demands was particularly difficult for women with comorbid mental health conditions and those with intergenerational child welfare involvement. They also note the differing mandates between substance use and child welfare fields and the resulting lack of across providers. And the abstinence-based policies generated fear of child removal and ultimately deterred women from accessing care. At the population level, 4 articles mentioned punitive approaches, including child welfare laws and apprehensions at birth. Many population factors also manifest in the context of individual and institutional levels. And so, for example, one of the studies documented the ongoing fear of social exposure and shaming around child removal. And another study noted how women were branded as uncaring or abusive because of their substance use, which only further impacts their ability to engage with programming and child welfare services. And so, while these barriers have been really well documented for at least a couple decades now, they do unfortunately persist today. And so this article is a peer-reviewed qualitative study that was conducted by 2 authors from the School of Social Work at Florida Atlantic University. And it was part of a larger photo voice project that started originally to examine perceptions of motherhood among women with lived experience at the intersection of child welfare and recovery services. The original article was published in the previous year, so in 2021. And the analysis presented in the current article focuses specifically on women's experiences with the systems and agencies involved in their lives and makes recommendations for social action and change. So the primary finding that ended up in the title is that the shared perception among mothers that when a substance use disorder is involved with the child welfare system, it's really easy to fail and hard to succeed. They described encountering child welfare workers who lacked empathy and competence and who were working in an environment with high turnover and heavy caseloads. They shared that child welfare workers' practices and communication norms often conveyed to them the perception that they didn't matter. And that from their perspective, in the midst of trying to recover, interactions induced fear, confusion, and degradation. And the emotional impact of these interactions was described by mothers to result in feelings of defeat and an increased vulnerability to relapse or increased substance use. And so the 3 sub-themes that emerged were disempowerment, incongruent system design, and the need for empathetic and equipped caseworkers and relational support. Their collective stories highlighted numerous barriers impeding substance use recovery and family reunification, and also a central theme of women identifying how powerful empathy and encouragement was in their experience. This is just one of the photos from the Photo Voice project, and a participant took this from her car in the parking lot, depicting the view of the child welfare office, and just noting that she found herself here really often feeling excluded from her child's upbringing. This is just a quote from another one of the participants. So the caseworker said, "You're going to leave here right now. You're going to go use because you're an addict, and that's what addicts do. They ruin their lives and they use, and that's what you're going to do." And I didn't even plan on using that day at all. That was the last thing in my head until she mentioned that, and it kind of engraved into my brain And it just gave me the case of the efforts. And I got to this point where I thought, they already think I'm going to use, everyone thinks I'm going to use. They just took my baby from me and I can't lose anything else at this point. So I might as well. And then I relapsed on heroin. So there are, of course, limitations to this kind of study, including small sample size. But the next article, I think, highlights that this risk of relapse is more than just anecdotal. So this study is a peer-reviewed qualitative study. It was conducted here in Vancouver. The objective was to identify gaps in overdose prevention strategies for mothers who use drugs and the impact of institutional practices that can increase overdose risk in the context of punitive drug policies and a toxic drug supply. Semi-structured interviews were conducted with 40 mothers who used what they defined as criminalized drugs, mainly opioids and stimulants. And this was part of a larger study looking at the implementation of 2 women-only low barrier safe consumption sites. And just to give an idea of the population, 31 of the 40 women had experienced homelessness in the previous year, 21 had been in foster care, 30 had been previously incarcerated, and 15 reported experiencing at least 1 overdose in the year before the interview. So they identified 3 primary themes. One was mother-child separation resulting from gender-based interpersonal and institutional violence. So institutional separation was routine among participants and experienced as structural violence, systemic discrimination and stigma against mothers who use drugs. Participants often described MCFD as being in the business of taking children, something that influenced most of their interactions with their supports due to being aware of the reporting requirements around child welfare. Child separation as a risk for overdose. So numerous participants described an increase in overdose risk following separation from their child or in response to the stress associated with custody-related drug surveillance, which includes both increased drug use in a setting characterized by an increasingly toxic supply, as well as using or injecting alone to hide their drug use. So many participants reported significant increase in drug use after separation from their children as a means of coping with the grief, while also navigating the expectation of abstinence to regain custody. And finally, contesting discourses and stigmatization of mothers who use drugs. Several participants described their drug use as mitigating social suffering, including the impact of child apprehension. One participant expressed concern that many mothers actually wouldn't even access a women's only safe consumption site for fear of being reported to MCFD. And many participants noted that the stigma of being seen as a bad mother combined with the pressures to achieve abstinence for custody or visitation intensified the grief of child removal. So the article really concluded that the institutional practices oriented towards drug abstinence, so increased surveillance and drug testing, produce paradoxical effects with the potential for severe health-related harm for moms and for babies. They also noted that the intersection and experience of drug use, overdose risk, and custody loss can't be divorced from the ongoing effects of colonialism, systemic racism, which permeate Canada's criminal justice, health, and social systems, and for which Indigenous women bear a disproportionate burden. Custody loss heightened vulnerabilities such as poverty, homelessness, and increased substance use, which in turn also decrease their chances of regaining custody of their children. And the article further concludes that without an extensive overhaul of criminal justice, medical, and child welfare systems, mothers will continue to be at risk for custody loss. And efforts to reduce fatal overdose among these marginalized populations will remain limited. And so while this study didn't intentionally look at child welfare involvement, it dominated much of the discourse with these women in their interviews. And just to point out the previous limitation that they recruited from these safe conception sites. So unfortunately, they didn't capture the experience of women who were not comfortable using those sites due to fear of child welfare reporting. This is another peer-reviewed study, quantitative study that was published in 2021. And the intention was to describe the prevalence of unintentional overdose in a group of marginalized women comprised of sex workers and women living with HIV in Vancouver, and to examine the association between child removal and recent non-fatal overdose over an 8-year period of time. So they also sought to explore this association for Indigenous women, given the colonial history of intergenerational family separation. So there's a fair amount of qualitative research which has described the impact of the child welfare system on maternal well-being, but very little quantitative outside of a 2021 study in Manitoba that actually found that mothers whose children were taken into care have greater rates of both avoidable and unavoidable mortality. This study used a merged data set of 2 community-based longitudinal cohorts of over 1,000 marginalized women here in Canada. So the ASHA study, an evaluation of sex workers' health access, and SHANA, which is sexual health and HIV/AIDS, women's longitudinal needs assessment. And approximately 42% of the participants in these cohorts were Indigenous. So at enrollment and biannually, participants in both cohorts completed an interview administered by a trained community interviewer. Their analysis suggests that after controlling for known co-founders, women who have a child removed experience higher odds of non-fatal overdose, and that these odds are highest among Indigenous women. These findings are consistent with an emerging body of literature establishing the links between child custody loss, grief, and maternal morbidity. And it is important to note that this is a complex pathway, and it includes multiple mediating factors that both increase the risk of overdose, but also increase the risk of custody loss, including economic and social policies and discourses that shape public policy for poor and racialized women. It also underscores the role of prohibitionist drug policies together with the child welfare system in exacerbating the risks of child custody loss and subsequent potential for maternal overdose. And it highlights the immediate importance of increased cultural safety education for care team providers to understand the constellation of colonial policies which continue and impact Indigenous women on a daily basis. The authors note a limitation with regard to causality. So they do note that while they found a significant association between child removal and overdose, they can't conclude that it was a causal effect. Just to further highlight the disproportionate harm caused to Indigenous women, the CEDAR project is an Indigenous governed prospective cohort study that involved 793 young Indigenous people who use or used drugs in Vancouver and Prince George. It's important to recognize that CEDAR participants are intergenerational survivors of the residential school system and survivors of the 60s scoop. And that now as parents, they're also profoundly impacted by the millennial scoop. This study demonstrated that young Indigenous women who recently had a child apprehended were almost twice as likely to attempt suicide, even after controlling for demographics, past and recent trauma, substance use, and sexual vulnerabilities. These findings contribute to an emerging literature examining the harms of having children removed on the health and well-being of young Indigenous mothers who are entrenched in substance use and who have complex traumas. Despite these challenges, though, Indigenous spirituality, language, tradition, and culture have endured and serve as a foundation of resilience and resistance among young Indigenous women who have used drugs. The authors conclude that stopping cycles of apprehension and respecting Indigenous self-determination over child welfare is critical to the future health of Indigenous children, families, and their communities. So this is another study that explored the lived experience of postpartum women attending outpatient substance use programs for opioid use disorder. The study was conducted in the US, and their current context is pretty similar to ours in that there's an ongoing opioid crisis, as well as a lack of substance use treatment catered specifically to women who are pregnant or parenting. The authors recognize the need for further research into the postpartum period for these women, quoting another study that found that women with opioid use disorder overdose more frequently in the postpartum period compared with pregnancy, with the highest rate occurring around 7 to 12 months. And the thought is that this is possibly attributed to loss of prenatal resources, the shame and stigma around withdrawal symptoms in their infant, or a lack of specialized resources for postpartum women who have opioid use disorders. Women in this study reported experiences of stigma, a fear of being reported to child protection. Specifically, women shared experiences of fear of being reported while being in treatment, and receiving inaccurate or inconsistent information around whether they would be reported or not. They noted that children were the primary motivator for staying in treatment, a lot of concern for the welfare of their infant, and barriers to actually getting to treatment. But overall, the fear of being reported to authorities and the potential for child custody loss guided all aspects of women's decision making. The authors also pointed out additional data that demonstrated that states with more punitive reporting policies have higher rates of neonatal abstinence syndrome, possibly reflecting the consequence of women avoiding care out of fear of being reported. So that really emphasizes that the harm occurs in punitive and stigmatizing policies, which can result in really tragic outcomes, both for women and for babies. And we can't necessarily remove this fear for parents, but we can work on how we communicate with them about reporting, about being transparent, and supporting women to navigate child welfare involvement and their expectations. It also emphasizes the role for continuity of care for women, given the known rates of relapse postpartum and previously presented data around overdose and suicide risk upon removal of children. And finally, as with several of the other studies, the authors didn't set out specifically to look at this piece around child welfare, but it continues to come up for women as a really critical factor in their experiences. So I just want to share in some of the literature around collaboration between systems and models of care that support individuals who are experiencing perinatal substance use. But I also want to highlight that Indigenous leaders have long advocated for jurisdictional control over child welfare services as an inherent right, and that this is actually critical to the well-being of Indigenous families. And so Bill 92 was passed in 2019, and it aims to recognize Indigenous jurisdiction over child welfare and affirms the rights of Indigenous communities to develop policies, laws, and practices based on their particular histories, cultures, circumstances, and establishes national principles that must be followed by every person providing services to Indigenous children. And so while I want to discuss solutions, this is what's really needed is a return of child welfare to Indigenous communities. And this is a great step forward, but like I said before, it remains to be seen whether it will be appropriately resourced and funded. So in the 1990s, several communities began developing integrated programming in response to the needs of pregnant and parenting women struggling with substance use. These programs were designed specifically to address the multiple barriers that exist for women who use substances. As discussed, one of the biggest barriers is fear of losing their children, in addition to things like guilt and stigma. The programs also address other issues that we talked about, including poverty, homelessness, gender-based violence, trauma, legal issues, and loss of cultural connectedness. The programs draw upon Indigenous knowledge, and they collaborated with Indigenous women and communities in their design and evaluation. And the article outlines 5 best practice elements of these single access multi-service models. So number 1, engagement and outreach. All the programs developed innovative strategies to build trust through trauma-informed practice, and also provided lots of practical support. The second is harm reduction, so enabling women to access all the services they need in one non-judgmental space. Recognition that success does not require abstinence, and that care and support are not contingent on addressing substance use. Cultural safety. So all of the programs in this article found that substance use is frequently tied to experiences of violence and trauma linked to histories of colonialism, residential schools, and migration. And this has meant offering specific programming for First Nations, Inuit, and Métis women, collaboration with Indigenous organizations, and an understanding that a lack of trust and a power imbalance between patients and providers affects care and treatment. Supporting the mother and the child together. So single access models view moms and babies as a dyad, and these programs have recognized that the significant rate of child removal for women who use substances doesn't lead to better outcomes for mothers or for children. And then finally, partnerships. So these programs have built partnerships with numerous services, including child welfare agencies. Social workers create the opportunity for women to focus on their immediate needs, develop safety plans, and ensure that women are supported in navigating the child welfare system. The Co-Creating Evaluation Report was published in 2021 by Nota Bene Consulting Group in partnership with the Center for Excellence on Women's Health. And it's an important piece of gray literature that resulted in numerous subsequent publications. So they conducted a 3-year-long evaluation of 8 different holistic multi-service programs in Canada, serving women at high risk of having an infant with a prenatal substance exposure. And they visited each program twice, at least a year apart, to interview clients, staff, and service partners. So they did a total of 424 interviews, 108 with staff and 256 with clients. So this is one of the studies that came out of that, and it affirmed that the partnership approach is the best practice in engaging pregnant and parenting women with substance use issues, mobilizing the full range of social and health supports that they require, and overcoming systemic barriers and service gaps. So this particular study looked at the qualitative interviews that were undertaken with program managers and staff and service partners during site visits in 2018 and 19. And then they categorized them into two subsections, so partnership characteristics and partnership benefits. So all of the programs in this study relied on both formal and informal partnerships, delivering services through a mix of program staff, in-kind support, and contracted or co-located services. Common partnerships included child welfare, primary health care, public health, prenatal and postnatal services, and specialized services like addictions, mental health, maternal addictions, and opioid agonist therapies. The benefits that we're seeing were that partnerships enhance access to services and increase the partner's understanding of the client experience, the impact of trauma and interconnected issues like substance use. And it promotes shifts in provider attitudes to support best practices and improve mother-child bonds and child welfare outcomes. And some programs co-located child welfare workers actually on site and also supported Indigenous cultural connections. So ultimately, partners' greater appreciation for clients' experiences and support needs has resulted in benefits for clients, most notably improvement in the mother-child connection and child welfare outcomes, as well as access to prenatal and postnatal care. And they noted that over time, there's a noticeable increase in the number of infants who are in their mother's care. This is another one of the studies that came out of that co-occurring evidence study. And this time it focused on the interviews that were conducted with the clients. So again, a number of key themes, but I'm just gonna elaborate on a couple. So programs focus on social determinants of health, The wraparound services ensure women access a wide range of needed care, as well as prenatal, postnatal, and mental health care. On-site substance use and trauma and violence counseling and support make a pivotal difference. So both one-to-one and group counseling. And clients really express that relational approaches to care and harm reduction, trauma-informed, culturally safe care promoted a sense of safety, honesty, and trust, which is particularly important given most of these women had had bad experiences in the past. Program support in relation to the child welfare issues promotes collaboration and common understanding of expectations and helps prevent child and infant removals. So many clients express a deep appreciation for the assistance, accompaniment, and advocacy they receive from program staff. And many also stated that they believe that the program support made a critical difference in enabling them to keep their infant or regain custody of other children that were in care. The conclusions of this study are really similar to the previously discussed study that explored staff perspectives. So while both are important, the fact that service providers and clients are saying the same things about this type of service model adds credibility to the findings of both studies individually. I feel like we're short on time. I'm going to skip this one. So this study presents an evaluation of findings from the Her Way Home program in Victoria and was related to cross-sectoral service collaborations and outcome for service partners as well as women and families. So similar to other one-stop programs, Her Way Home offers a multi-service drop-in and outreach programs for pregnant women and new mothers who are affected by substance use and who may also be affected by mental illness, trauma, and violence. The program opened in 2013 and the evaluation occurred between 2015 and 2017. It employed a mixed method study, so semi-structured interviews, questionnaires, focus groups, program data, and document review. And so the evaluation just really detailed that one of their most critical service relationships is with MCFD. Her Way Home case managers offer women support with an accompaniment to their meetings with child welfare workers and in court. And they act as a communication bridge between MCFD and the client, ensuring that the woman understands the worker's safety related concerns, but then also provide support to address those concerns. They also advocate for women and support them in communicating what steps they've already taken to keep their kids safe. And what's already been put in place to ensure their child's safety. They provide support in emotionally charged situations. So for example, if a child is being removed, one of the workers reported that lots of intensive support is provided if a child is removed so a woman doesn't spiral down due to grief. Her Way Home maintains collaborative relationships with child welfare workers, which were noted by child welfare workers to enable creative planning and a strong circle of support for clients. So one of those workers actually noted that Her Way Home provides the type of support that allows me, a child protection social worker, to leave a child in a situation with a degree of risk because there is a plan in place that we've created together. Nearly all the participants shared powerful stories illustrating positive outcomes of the program in relation to helping prevent their infant from going into government care. And that, or regaining custody of other children, or even improving relationships with children that weren't in their care through access at Her Way Home. They were recognized by service providers as fulfilling a unique role in the community because this work is really recognized to be very intensive and time consuming, and no other agency has the mandate, staffing, or experience or time to take on. The program has also led partners to a clear understanding about women and their substance use issues, including approaches and harm reduction. So several community partners noted that this knowledge actually helped them lessen the judgment that they felt towards women who use substances during pregnancy. And findings of this study just further support the existing literature that wraparound programs who uphold harm reduction, trauma-informed, and relational care have helped improve women's health and social outcomes, including the prevention of children going into care. This is just a really quick map of 8 of the programs that were in the study. And so just to note that 3 of them are actually here in BC, and the one here in Vancouver is Sheway. Okay, so in terms of application to social work practice, number 1 is just really comprehensive biopsychosocial assessment. So we need to be reflective of the significant concurrent vulnerabilities that these women are often experiencing and elicit women's stories and lived experiences in the context of mother-baby togetherness. And ensure you're assessing risk and providing support, especially during those really high-risk times postpartum and after child removal, if that occurs. Harm reduction and trauma-informed practice. So social workers play a really key role in practicing and modeling these approaches. And when we integrate harm reduction without the expectation of abstinence, we offer a safe place for people to talk about their substance use. Because if people aren't feeling safe to seek care or talk about their use, we can't support them and they won't get the care that they need. Challenging stigma, so increase awareness and understanding of substance use during pregnancy and actively address stigmatizing language and comments in your workplace and even charting. I have a resource for this on the next slide. Cultural safety, so identify the colonial context of social work and be intentional with Indigenous patients about honoring them and their chosen family, and remember that harm reduction also includes reducing the harms of colonialism, and ensure patients' cultural supports are present and included in all meetings and planning. Strengths-based practice, so social workers play a really big role in eliciting strengths and communicating these to other providers and partners. And so really thinking about what women are already doing to keep themselves and their children safe. Partnerships, like we just talked about, advocate for women and support them wherever possible in navigating the system. Connect women to specialized services, including these multi-service programs if they're available in your community, and family-centered treatment wherever appropriate and if that's possible. Women identify a big need for these programs that include their child and their partner in their recovery. And finally, counseling. If you work in a counseling capacity, just taking into consideration the significant grief and loss involved with having a child removed or at risk of removal, and the intergenerational trauma for women who have experienced this for multiple generations. Substance use counseling really needs to involve an awareness of these factors, as well as timelines that have often been imposed on women, and sort of balancing solution-focused approaches with the fact that this is really deep-rooted trauma. So these are just some resources. I'm happy to send them out in an email if that's helpful. The Perinatal Blueprint, developed by BC Women's Hospital, kind of talks about a continuum of care. Mothering and opioids is really, really helpful for addressing stigma and how you might do that practically. The FIR model of care is just a really interesting document about how families in recovery at BC Women's operates. And then I've included this policy brief on Indigenous harm reduction and reducing the harms of colonialism. And I think that is it.
If anybody wants to take the questions, you're welcome.